So you see, the thing is that if you don't see a lot, that means that you don't know the rule of how you approach these cases, and you try to then to switch your mind to the picture matching. However, the picture matching, I told you there are cases which might work, like, for example, granular cell tumor. You can picture match that, and you probably will be correct. But there will be a type of lesions which you tend not to be able to picture match, and they will need to use an approach. And this is what the melanocytic lesion in general are some of those. Obviously, I cannot cover the entire melanocytic lesion. I told you before, in an hour time, we cannot really do that. But what we can, or we will be doing, we will revisit it every time we practice and every time we come across some of those, and we will build on an approach. However, when you are dealing with a melanocytic lesion, there will be some important rules to identify and understand. Obviously, we all know that you have, of course, the benign melanocytic lesion, and then which tends to happen at a younger age group, and then you have the malignant ones, which happens in a little bit late adulthood or in an elderly populations, or sometimes the commonest really is 45, 50, 55. This is where in the United Kingdom we tend to see these melanocytic lesions coming, but also it doesn't stop people with 70, 80-year-old to develop it, obviously. But this rule is very important, and the age then becomes very crucial in the exam. It's also important to understand that some melanocytic lesion, as you all know, might occur in childhood, and as the patient grows up, then either the lesion might change in the name, or change the shape, or become involuted, or develop develop malignant transformations on what has been pre-existing. So this is also important. So it's important to identify if we have any pre-existing things in melanocytic lesion or not. One thing as well that I realized a lot of people do as a kind of a mistake is that they try to jump directly to the lesion, and they completely ignore the fact of what the background looks like. Because if you are going to develop a melanoma in majority of the Caucasian population, that what does that mean? That it means that you probably have been exposed a lot to the sun. Either you're sitting a lot on the seaside, or you just having a lot of you work under unexposed conditions as occupation-based things, that you have to be exposed a lot to the sun. So this is, again, an important thing. So if you've been given an occupation for someone, a builder or a farmer or something, then this is important, because that means that this person in particular has been exposed a lot to the sun. So all these little things are important when you are dealing with the history. Now, the other things as well, which I would like you to highlight here, is that when you look into the low power again, as we said, and we emphasizing onto this fact. And I wanted you to see what type of specimens you are dealing with. And from here, you can realize that this is not a biopsy. This looks like a sections taken from an excision specimen. So this is important as well, because when you've been giving an excision specimen in the FRCPath exam, that means that we would be requiring you to apply our data set item. So this is also an important things to remember. If you are in the biopsy area or category, then you probably will be only required to give a diagnosis and maybe just some initial information about if you think that this lesion is deep, if you think that you can see frequent mitotic activity, some extra bits for melanocytic lesions. But it is important to remember that if I am to give you an excision and you have a malignant melanocytic lesion in it, then you will have then to go for the data set. For those who never opened the data set for the Royal College, I think you need to open it, you need to rehearse it, you need to try to understand how they work. Once you've been through one or two of those data sets, it will be absolutely fine. The rest will be easy. And then you don't have to memorize it, but you need to understand it. But for melanocytic lesion, you need to see what we mean by the data set items. You need to remember all these criteria that we need to include in our report. So it's only saying if this melanoma or not will not save the day for you in the exam. So you need to know in the melanocytic lesion, you need to understand these things properly, and you will be able to see it. The things also to highlight when you look at the low power is the sun damage effect. So if you need to look into, for example, this collagen, and you can see that you get these effects or these denaturated collagen fibers, which can tell you that this is a sun-damaged skin. And then that tells you that this melanocytic lesion is probably start to develop as a result of irritations to ultraviolet radiations. And then there is a chance for these lesions to become malignant. So this is also an important features to highlight. One other things I want you to recognize before even you touch the slide on the low power is to go to try to judge the epidermis and see if the epidermis is thinned out, or is it like atrophic, or does it look like normal, or is it a little bit on the hyperplastic or acanthotic side. You will find that useful later on, but just remember that it is important. The other things as well to remember that some melanocytic lesion will have the tendency or more tendency to happen in the exposed areas of the body. And this lesion which we are dealing with now, it's one of those. You can see it says the sun damage effect is very pronounced here on the side. One thing as well, which I wanted you to always do, is to go to the edge of the biopsy, because that will tell you what is the normal epidermis thickness in these patients will look like. And then when you go to other areas of the lesion, you will be able to understand more about it and more of what has been happening. So for example, if I compare what I have just showed you to an areas like here, so this area here, which let me just try to annotate this. Here, this area here looks a little bit of atrophic. So if I go at a higher power, you probably see that this epidermis has got approximately 3 layers, which means that it is a little bit atrophic. And obviously that means that some melanocytic lesion, when it is get produced, it's one of its features to try to make the epidermis in some areas a little bit atrophic. Hello, can you hear me? Sorry, some people say you cannot hear me. Are you able to hear me? Just say yes. Yes, excellent. Okay. Sorry, just maybe a delayed message or something. By the way, anyone would like to ask questions, just put it in the chat room. I have it open on the side of me here so I can see what your queries are. Okay, very good. Thank you. So if it is breaking in between, that means that your internet is faulty. I'm using a very high broadband width here. So if the sound is breaking, you might need to close some of the devices in your home, on your workplace, because that means that there's too many devices open. But let's carry on. So yes, the atrophic epidermis, we were talking about some areas of atrophy. You can see it's not going to be universal, but it's important to highlight things like that, okay? The other things as well, which people tend to try to judge when you discuss or approach a melanocytic lesion on the low power, which is important to assess, is symmetry. Now, the symmetry has got a lot of concepts in the people's minds, and I find it fascinating how people, like how the word symmetry of melanocytic lesion is overused or overutilized, sometimes based on no clear understanding of what it is. If I am to deal with a lesion that as long as this one, as you can see, it is like 1 meter long sometimes, and you go from one side to the other side, and then you forgot where you start and where you finished. In a lesion like this, can you see the extending from nearly something like here into this area here in the far corner, and then going all the way to the other side, which is just here. So this is basically a very long lesion. So if I ask you if that lesion is symmetrical or not, you will say, you will hear a lot of, I'm not sure. Well, it might be, I think it is, I think it isn't. And then you tend to get this problem, which is an important feature, because sometimes people tend to describe the melanocytic lesion as symmetrical, which gives you a benign phenomena and benign features. So what do we mean by symmetry? Let me put a sample, and you might like it, or you might not, or dislike it, or you might agree or disagree with what I'm going to say. We live in a democratic society. This is a very democratic meeting. You can all disagree with what I'm saying. But let me just tell you, the symmetry means, in simple terms, is if you start your lesion with a large nest, you should end the lesion on the other side with a small nest. And by the way, symmetry is only a judge that you will use for the junctional component of your melanocytic lesion. So if you are dealing with an intradermal melanocytic lesion, then you should not be using the word symmetry here. Okay, symmetry is applied for the compound lesions, or the lesions which we tend to have a junctional component or pure junctional component. So if you start with a large nest on one side, you should end with a small nest on the other side. So this is number one in terms of symmetry. So let's me just use the annotations again, the marker here. Very good. So if let's say your lesion started somewhere here and ending there, then if you have a large nest, junctional nest here, you should also have a junctional nest here. If you have a small nest here, you will end with a small nest here. If you have a lentiginous melanocytic proliferations in continuity, cells in continuity, lentiginous, then you will also have it here on this side. if you do have sporadic, then you should start with a sporadic and end with a sporadic here and there as well. The other thing is that if you do have a mixed populations like nests and cells starting on one end, then you should also have nests and individual cells on the other things. So I made that point clear now. This is what we mean by symmetry. If you think that you can judge the symmetry by looking at the lesion, yeah, triangular, yeah, it looks okay, the shape looks very symmetrical on either side, then you have been applying the wrong rule here. Okay, so the right and the correct rule, which you will get from the people who are expert in the field in dermatopathology, they will tell you exactly what I have just said. Okay, so that's for the symmetry of the lesion. And this is quite important to judge it on the low power. So that is quite important to judge at low power here. And just 1 second, let me just close that window, which just popped up. Very good, thank you. Yes, so you judge, so this is an important judgment on the low to medium power. You basically go on either side and judge that. So the second thing as well, that what you will need then to do is to decide if you are really dealing with a tumor that has got a junctional and a dermal component, or either a lesion that we are dealing with has got only a junctional component. And you will understand why this is important as we go throughout this lecture. But let me just show you what I mean by this phenomena. You see here, you have a little bit of some cells, and then as you go along, they are trying to form little and small nests, and then you get areas where you become more confluent with the proliferations. You get some melanocytes proliferating across, extending into the adnexal structures, which is an important feature. We'll come back to this. So I'm just showing you guys the lesion, especially for those who did not see the lesions on the link that we did send from before. But just to see how florid this lesion has become, it's all, as you can see, happening. Most of the actions really taking place at the junction, hardly anything in the derms, maybe some pigment incontinence here, some melanophages, but I am carrying on, going all the way to the other side, and you can see again confluent proliferations, very confluent here in these areas, again extension along the adnexal structures. So just bear with me. I see how long this lesion is. It is like a meter, as I said, as I told you before. But we are going, so I'll go a little bit faster now because you got the concepts of what I'm trying to show you, and then we will come back to the center of the lesion in a minute. So, but this approach of what I have just shown you is very important. And then you go to the far edge of these lesions and look, we are ending with more sporadic cells. So if I am to tell you if this lesion is really symmetrical or not, probably it is, but there aren't a lot of these are here on this side, I would say, a little bit more sporadic. Like you can see, there is a lot of normal epithelium between the melanocytes, and they are not trying to form these little nests that we saw before. So this is the edge of this lesion now. You see, we ended here. And then what you can see, these cells here are more sporadic. So I just want you to believe that story, because seeing is believing sometimes. So let me just go to the other side again of this lesion, because this is a very important concept. And that will stick to your mind now from this case, so I don't have to visit these concepts again and again and again. Look, here we are getting the sporadic cells, but we are getting a little nest. This is the far end of this lesion as well, okay? So now this is more a mixed population here with nests and cells. But on the other side of this lesion, we didn't really have nests. We have only some sporadic cells, and they were even more sporadic than what we see here, a little bit more confluent. So this is one very important features that you need to think of. The other things as well, which, okay, so we finished with this symmetry business now. The other things which I wanted you to understand about this particular lesion, that there are areas which, like here, has got lentiginous proliferation, and it is junction. Then you will be in the area of what we call it, the differential diagnosis will be purely and utterly between what you would want to call it a lentiginous melanocytic nevus, which is a variant of the junctional nevus that tends to have nests as well as lentiginous proliferations, which is a continuous proliferations. For those who are not familiar, I am so sorry, but I would have to go to sometimes to the basics of the word lentiginous in melanocytic lesion means that we are dealing with a very continuous proliferations of the melanocyte. So this phenomena, you can see it in the lentiginous melanocytic nevus, which is a subtype of the junctional nevus, or you can see it in a condition that we tend to call it lentigo maligna. Now, what it is in the lentiginous melanocytic lesion, the melanocytes are bland and uniform. They tend to form more nests sometimes than what we see here. This here is pathetic a little bit. They are trying to form nests, but not a very well-formed nest. However, in majority of the junctional nevi, they should succeed in forming a large nest. That's part of their attributes. They can form nests, while here they are trying, but they kind of like you feel that they are failing. And this is why it is difficult for us to pick up on this nest. But you can see if I, let me just spotlight here, you can see here, they are trying to form nests and they can succeed. You can see there's a little nest here has been formed. But let's also remember something which is important concept, that when you look to the melanocytic lesion nests, you need to understand where the nests are, because in melanocytic lesion, there is a difference between if the nest is in the papillary dermis, here, if the nest is at the tip of the rete ridges, like here, and this one, and if someone said you cannot see this annotation, so let me try the arrow. Can you see the arrow? Can you all see this arrow, please? Just if you let me know. Yes, excellent. Okay, so we would use the arrow instead. That's absolutely fine. Thank you. So if the nest, what I'm trying to say here, that if the nest is in the junctional melanocytic nevi, the normal, the benign ones, the nest will try to form at the tip of the rete ridges here. However, if your nests are is middle of nowhere, like this guy here, then this is not a tip of a rete, this is not the papillary dermis, and therefore it is tricky. You see, this here, this is not where you want it to be, and then this is abnormal site for this nest, and this is also an important features that you need to recognize when you look at this lesion. The other thing is that majority, if you can get a little bit of a halo or attraction artifact around the melanocytes when they proliferate in the epidermis, that is absolutely fine. But the problem will relies on when you have a lot of halos, then this is a problem here, okay? And this will take us to the diagnosis of this lesion. Because if I tell you that every single melanocyte here is getting this white halo around it as being glorified melanocytes, you see, this is an important feature because this is not normal. Normally, the melanocytes in any junctional nevi, maybe 1 or 2 or 3 of them might have a halo, but not a lot of them should have that. And then this is abnormal. To have this constant halo from one cell to the next one, to the next one, this is a purely and utterly abnormal. And then even without me assessing any atypia, you can see I didn't touch the slides yet, you see, but I can tell you from the architecture of where or the location of the nests, I can tell you from the fact that this is lentiginous proliferation. I can tell you also from the fact that there is a halo phenomena or attractions that's happening around the individual melanocytes, then these are all abnormal features that automatically I think that this is then abnormal and atypical, or I'm heading towards the malignant. But you can see why I'm careful in choosing my terminology a little bit, and you will see what I mean in a few minutes and why I'm not trying to push for diagnosis. The thing is that what I wanted then, yes, you're absolutely fine. You can go to the high power. This is unfortunately our highest on this slide. But even at this power, you can see that the melanocytes have got a different sizes. Some of them are small, some of them are big, some of them has prominent nucleoli, some of them are very dark, and some of them are very light. And they, if we go in a higher power, you will see that they are a little bit of irregular nuclear membrane. What yes, I will say these differentiations between dysplastic and lentigo maligna in a second. And I will tell you also how to exclude the dermal invasion. Don't worry. We will go through all of those things in details. But let's take it one step at a time. The other thing is that, okay, so this is atypical, and it is lentiginous proliferation, not forming a lot of nests, and then has got this constant halo that's going around from one cell to another, which is a phenomena that you don't see in dysplastic nevi. You only see it in a category of lentiginous melanocytic lesion, that if you upgrading the lentiginous nevi or the solar lentigo, or because it doesn't necessarily start on a pre-existing lentiginous lesion. These lesions actually are more common to start on the background of solar lentigo or lentigo, for those who like the American pronunciations of the words. Okay, so lentigo, then we will take it to the atypical part of it, which we call it, no, this is not the same, okay? This is not like superficial spreading melanoma, and we will come to this as well, okay? But here we are dealing with an area that we call it lentigo maligna to start with, by the descriptions which I have just said about the lesion. So again, lentigo maligna is a lesion that tends to happen in the face, in the upper chest. It happens also in the forearm or the arm and the hands if they are exposed to a lot of sun. But more common that you will tend to find in the sun exposed region. And it is kind of like very linked to the face and upper chest in a way. So the lentiginous proliferation is a very important feature for it, and does not tend to form a lot of nests or trying to form a nest, but the nests are very pathetic, small, and not very well formed, as that guy, which you just see it in the middle of the picture now. You know, you can see a few nests here, not very well formed. Probably you're talking about trying. There is a lot of these nests are actually reedy, but at the edge of it, yes, it's trying to form the nest, but not very good. And as I showed you, the nest that extending across the adnexa here, which about 5 or 6 cells, but not very well formed nest. But the extension across the adnexa is one of the features of this lesion. And this lesion does not tend if you are dealing with an lentiginous nevus, like a junctional melanocytic nevus, it will try to avoid doing that, you know. It will try to stop by where the adnexal epithelium is going to start, like the hair follicles, and it's not going to spread across this. So this is also a very important feature that we have to pay attention to. The thing is that there is now the terminology of lentigo maligna in a lot of books and in teaching session. You will find it a little bit mixed up in the heart and mind of a lot of people, because lentigo maligna per se is a condition that tends to be a pre-malignant, but it needs excision, you see? So this is like in the normal nevi, like a very, very dysplastic nevus. I just highlighted to you a minute ago that the cells are basically very atypical. So this is important, you know, that the cells are very atypical. If you look into every melanocytes in this field, which I have put now in the screen, every melanocyte looks different from the one next to it. So this is an exaggerated and marked atypia. And then there is an upgrade then for this term, which then you call it lentigo maligna melanoma. Now, lentigo maligna melanoma, then you have the full-blown, the lentigo maligna now is going to change to the becoming a melanoma, and some of you start to comment already that yes, when we start to get this pagetoid spread in some areas, that the melanocytes, as you can see, upward migration here and there. So usually you find that toward the center of the lesion, that this upward migration of the individual melanocytes, then this is what people refer to as the pagetoid spread. That's absolutely fine. But this is then become a lentigo maligna melanoma. So now you have a spread of melanoma into the epidermis. You see, just look at it and think of it that way for a minute. And this is important because then you can then label your patients as a cancer patients. Now, don't forget the world is changing. And I will tell you that not for particularly for the exam, but for even your day-to-day life, that if there is a huge difference between the devastating news of breaking a cancer melanoma to your patients, or just telling your patients you have a pre-malignant condition can turn into cancer, and therefore it is important to resect it with a safety margin. So that's important. The other things as well, I just told you a minute ago that in actual fact, if you get a cancer diagnosis with this pagetoid spread, that you will need then to excise with a wide safety margin. If you excise, if this lesion, as I told you, happen in the face, which is common to happen in the face for lentigo maligna, that's a common site for it, then how can you get the 1 centimeter clearance that you would require for melanoma? Then it becomes a very difficult area, because that will include a very disfigurement surgery, or you have to do a bigger flap transposition surgery, which is a very different story. You need now a plastic surgeon, you need to do maybe 2-phase approach, and a lot of things comes with this, and you will leave a scar anyway. But it's different between a simple excision that you will do for lentigo maligna. We will come to the superficial spreading, don't worry and don't panic. Just wait. Try to understand the lentigo maligna as it is, as a separate entity. And then I will show you the superficial spreading, and then you will see the differences. But remember that halo phenomena, which we get, this halo phenomena, you don't get it in superficial spreading malignant melanoma. So yes, the superficial spreading malignant melanoma tends to be an epithelioid to spindle cell-shaped cells, even within the nest and within the proliferation that happens in the epidermis that's got this spindled look to it. But in lentigo maligna, we don't. But in lentigo maligna, we don't have that spindle morphology. You can see the melanocytes are small. In actual fact, that halo that you see around the melanocytes is only a retraction artifact. This has nothing to do with the cytoplasm of these cells at all. And therefore, if you look into these individual cells inside the halo, you can see the nucleus and the cytoplasm, and these are not particularly spindled. These are just atypical melanocytes that has got this hyperchromasia and irregular nuclear membranes. And when the other things as well, which I wanted to highlight, that when you apply the pleomorphism on the melanocyte, you have to apply them all what we know about the pleomorphism as NC ratio, as nuclear irregularities, hyperchromasia, prominent nucleoli, irregular nuclear outlines, coarse chromatin, whatever you wanted, whatever comes to your mind. You know all these criteria which we learn in KG1, all of these you have to really apply them all, and then you will find them. And this will be important and crucial. Now, yes, some people, and I am one of them, to avoid the people from getting confused, especially dermatologists, when I put my reports on, the lentigo maligna melanoma will stand for the same icon of the melanoma in situ. However, we can have in superficial spreading melanoma, the one that has got this horizontal growth phase, you can have a pure epidermal or junctional melanoma that is malignant. But why it is important then for the clinician to understand that you are dealing with an lentigo maligna melanoma subtype instead of just only saying melanoma in situ? It is because of what you see here in this diagram. If I am to go into low power of this lesion, away from the area with the pagetoid spread, this angry area, that's usually you find it in the center of the lesion. But if you are to go to the edge of the lesion and you look here, this doesn't particularly look very angry. And here, if I am to get only this area alone, then I will probably call this area as a lentigo maligna alone, without the word lentigo malignant melanoma. But then the clinician or the dermatologist will need to know this subtype, because the wider excision, they have to go really wide, especially if they are in a biopsy or in a small diagnostic excision or incisional biopsy. Then if you were mentioned the word lentigo maligna in the eye of the dermatologist, that means that any area with any faint pigmentation in this patient face around that lesion then needs to come out, because that still might be pre-malignant. It is like when you deal with an in situ carcinoma and invasive carcinoma, so it is the same story here, but here we are dealing with melanoma in situ in a background of lentigo maligna. And so lentigo maligna alone is the pre-malignant. Lentigo maligna melanoma is the invasive one. Now, there is nothing to stop the lentigo maligna from going into the dermis. And then if they can go as a little clusters, they can go as individual cells. You know, don't overcall some stromal cells as melanocytes. If you are in doubt, it's always good to get your melanin marker in, melan A markers. I tend to do all my melanoma stains or melanocytic lesion stains with the counter stain. So I get the red immunohistochemistry, not the brown, because then you eliminate the fact that there might be melanophages, there might be something else. Obviously, if you are to get no pagetoid spread, so there's a question here saying that any pagetoid spread, you call it superficial spreading melanoma. No, I'm sorry to disappoint you. Pagetoid spread can be found in the lentigo maligna, and it can be found in superficial spreading, in both of them. So you have to judge the melanoma as per cells and as per what is happening in the background. Don't forget, there is also an important role, which is important here, that the lentigo, the dysplastic nevi, which I will also be discussing with you guys, the dysplastic nevi, when it becomes melanoma, then the will can turn into superficial spreading melanoma, and that is the more common scenario of developing the superficial spreading melanoma, that it's still ultraviolet and sun bath and all of those things that can lead to the transformation of the benign nevus to become a malignant. But here in the lentigo malignant melanoma, you tend to have the precursor lesion is lentigo maligna, and the precursor lesion for lentigo maligna is the solar lentigo. But it doesn't mean that lentigo maligna must have a solar lentigo. So it can have this as a precursor, or can start straight away as a lentigo maligna. And then now that's more clear now in your mind that lentigo malignant melanoma can either be the melanoma in situ with the pagetoid spread and a lot of exaggerated atypia, like what we see in a case like this, or it can be, on the other hand, on the area of the in situ with a dermal component, and then we are then dealing with melanoma in situ. I just started to mention, so there is another question, how you differentiate between the malignant melanoma and superficial spreading melanoma. The first and very important things to keep in mind and keep differentiating is the fact that the atrophic epidermis, which we saw it in some areas, it does not tend to happen in the superficial spreading melanoma. But not only that, but it is these lentiginous proliferations of a halo type melanocyte, these are not spindled cells. And these are not even epithelioid. And there is hardly trying to form a nest that I will call them kind of ill-defined nests. Can you see a little bit of ill-defined nests? Very haphazard nests. They are trying, but not very well formed. In the superficial spreading melanoma, on the contrary, you have a well-formed nest, and even on the well-formed nest, you will tend to have the upward migration that happens in the epidermis, sometimes happen for the entire nests. So the morphology of the cells is very important. The halo phenomena is very important. The distribution of the nest is also very, very important. Okay? More atypia, yes, more atypia and pagetoid spread are the main differentiation between lentigo maligna alone or lentigo maligna melanoma, and the nest doesn't contribute to the equation, no. A lot of books will tell you that lentigo maligna melanoma actually doesn't tend to form nests, but what I did see that I saw a lot of cases that they have the tendency to form a smaller nest. And a lot of people will tell you, yes, there is nothing wrong with that to form a nest, but it is in lentigo, what tends to happen when it tends to malignant, it doesn't tend to go up. The nested pattern is important for the differentiation, but we will come to this. I just wanted to share with you this case here. You see, so this is from Leeds, and I told you guys that we have the approval from Leeds virtual histopathology website to use their slides for these teaching sessions. And this is why I can use it. Now, this is another lesion. And as you can see, it is coming from the edge. Let me just show you the low power first, because then you will have some appreciation. You see, this is a punch biopsy. You can see the square shape of it, and you can see it is quite small. But you can see what I have just been talking about, that we have a little bit of some areas which has got this lentiginous. So now if you are going to judge the symmetry on here, that's wrong. And this is because we only see part of the lesion. So I will skip symmetry. So if you are to get a lesion on a biopsy that is still extending to the edge and the margin, you don't see where it ends yet, and you tell me this is symmetrical lesion, I will shoot you in your foot, because basically this is not going to be the case. So yes, melanoma in situ can be correct. Someone is asking if we use in the previous case melanoma in situ for lentigo maligna melanoma. I put them next to each other because melanoma in situ is correct, but you are not telling your pathologist, your dermatologist, that you might have a lentigo maligna in the background. So you're not warning your dermatopathologist that he might need to do a wider excision to get the lentigo maligna with the pigmented lesion that he can see obviously. And this is why, okay? So this is very, very important to mention the word lentigo maligna melanoma, and then in between brackets, melanoma in situ, if you see the marked atypia and the pagetoid spread. So we will come back. We are back now to this lesion that I'm showing in the screen. So here in this lesion, you can see that this is basically a lentiginous proliferation. You can see that the halo, which we talked about, can you see here? Every melanocyte has got that halo phenomena around it, okay? But what you can probably see that there are some gaps, and these gaps are important. And this will answer these questions about where it ends and where it starts. There is atypia, but it is not as exaggerated. Oops, it is not as exaggerated as the atypia, which we saw in the previous case. You can see that there are some melanocytes. That little chap here looks okay. These guys here, 1, 2, 3, 4. Let me just put the annotations to so you can follow me. Those guys here, you can see these are kind of like normal melanocytes in a way, but you can see the difference between this group here and these cells here. These cells are definitely larger. These melanocytes here over there are smaller. Okay, here these are larger. Okay, this one has got the halo in between. Can you see the halos that's circulating around these cells? Every single cell has got this halo. These cells does not tend to have this the superficial spreading melanoma will not have that halo phenomena. Okay, again, when you judge the shape of the cells, take the halo out of the equation first before you tell me this is spindle cells, because the halo can be spindle, but the cells is not. Remember that, right? So it is the cells with the cytoplasm inside the halo that you judge its shape, and it wouldn't be. So that is that's an important things. The other things as well, which as you can see when you go to the adnexa, just pay attention. It is going down into the adnexa, into the sides. So this is also an important. And then I wanted to show you again that you don't have really a proper pagetoid here, and no nests. You see, for people who love the idea of the nests, you don't really have the nests. So you probably start to agree that I am not particularly deluded, but maybe a little nest just here at the tip of this 3T, okay? But overall, not a lot of proper nesting. So this is when we are dealing with this kind of what we will call it the lentigo or lentigo maligna. This is alone, the atypia is not particularly exaggerated. There is atypia, there will be atypia. Don't take me wrong, lentigo maligna will have atypia in it, yes, but if you don't have a proper pagetoid spread and exaggerated atypia and a very confluent lentiginous proliferation in the area of the pagetoid spread, then you are not dealing with a lentigo maligna melanoma. Then I would say that this is only a lentigo maligna, but you still will the clinician knows that this is pre-malignant, and they need then to go and excise more. Okay, so this is just, I wanted to show you another example of these lentiginous proliferations to prove to you the point of the halo and to show you a little bit of a difference between the atypia. Like there is a little bit of some uniformity here, not very exaggerated, but unfortunately in these particular pictures, again, I cannot go to very high power because some images are not scanned at that screen. Hopefully I will be able to show you in other sessions some of scan slides that I have for my own, and then we will be able to show you that. But this is a tricky area, I know, and it is the concept here that you need to understand, okay, first of all, the site is important, because if you have a lesion in the back or in the thigh, and you are trying to give me a diagnosis of lentigo maligna, then I will tell you, no, that's not right, because that's not the right place for it. The second thing, if you are trying to give me a diagnosis of a lentigo maligna without the solar damage, then you are wrong. Then you're probably dealing with a diagnosis of lentiginous melanocytic nevus that just looks odd, because if you don't see a lot of it without nests and it looks lentiginous, then you might think, oh, it might be that one, okay? The third thing is that you need to see some areas of atrophy. Sometimes you might find the entire epidermis atrophic, but in the exam classic, if they are to get you lentigo maligna or lentigo maligna melanoma, I would think that they will have to give you the atrophic epidermis, because majority of the textbook will describe it in a background of, when they describe lentigo maligna melanoma, they describe it at the background of atrophic epidermis. And this is another important difference between this one and the superficial spreading melanoma, because superficial spreading melanoma does not tend to have the atrophic epidermis, does not tend to have this extensive solar damage that we will see it with this guy, okay? But this is here, again, going back to 3 layers, epidermis, in and areas like here. Let me just annotate this again. So here, you can obviously see that the epidermis in some places becomes 3-layered, and this is what I mean by that. Okay, so that is just to highlight that phenomena and make it clear. The extension across these adnexal structures is important, and that they give you some differentiation between the benign and malignant. And then, as I said, when we move, then we move to the point of the lentigo maligna melanoma, or melanoma in situ. But remember that lentigo maligna melanoma can have either the in situ one or can have the invasive one, or both, you know, like it can have in situ with invasive component. So remember that lentigo maligna melanoma can be applied for both. So it doesn't necessarily mean that you are only in the in situ category. But this is why I told you it is good in practice to put in between brackets melanoma in situ. So this is for this area here. Now, my plan, of course, and obviously, was to give you more insight into these areas, but it is ideal. There is an important thing you guys need to understand, that I do not prepare usually the talk. I take you guys through the case and I try to answer your questions and then explain for you what it is throughout the case and how I would approach this case. It is an important exam approach as well, because it will give you more insight, especially if you don't deal with this, you know. A lot of cases which I do select, I select the cases which has got a lot of confusions around it, and people can easily get it wrong in the exam, either in terms of terminology or either in terms of how you will interpret some of the findings. Like, as you correctly said now, some people don't have that clear differentiation between the superficial spreading melanoma and this type of tumor. However, I will continue in the next session with the differentiation between this guy and the superficial spreading and the other melanocytic lesion. The melanocytic lesion is usually will come in the exam. I think the short surgical usually, and you will have either one or two skin cases, and so that means that you will get either a one neoplastic, and if you are in the cohort, if you are to get the two skin cases, then you will have one inflammatory skin, like a vesicular bullous disease, like a granulomatous inflammation, something down these lines, or you will get the adnexal tumor or melanocytic lesion. But historically, these lesions melanocytic lesions are more common to come in the exam rather than the adnexal tumor, because a lot of people know a lot about the adnexal tumor, but so we cannot confuse you about them. But it will be. Yes, in this particular case, the Leeds case, so the question is, Leeds case is lentigo maligna, and because there is no pagetoid spread, but the case which I gave you on the past presenter website is the case which we started with is a lentigo maligna melanoma, which is a melanoma in situ, which is basically has got the pagetoid spread, has got the more exaggerated atypia, which was not difficult to see for the atypia. Okay, so that's just to differentiate between the two. So I can tell you that for those, specifically those who sit the exam from abroad, they tend to fail into the melanocytic lesions because you try to picture match rather than approach, because the nature of the region, especially if you are, as I said, in Middle East or Africa or in tropical countries, you don't see a lot of those lesions because it tends to happen more in the Caucasian population, as you all know, and therefore we tend to see more here. But then you tend to be more confused when you get it in the exam, because in a short duration of time, you try to picture match and then you tend to get it wrong. So this is one thing that tends to be difficult. But one thing I want you to not to be focused a lot on is this subtyping. I'm telling you this importance of subtyping because they are important for the real life as well, because it has got a lot of implication on the patients, how you label your patients. Is it really cancer or pre-malignant? But also it has got implication on the management, because the management of pre-neoplastic lesion, you don't need a wide margins. 1 or 2 millimeter will be enough, or sometimes up to 4 or 5 millimeter. But for melanoma, usually we need 1 or 2 centimeters clearance, and this will be very disfiguring for your patients, for your own sake and for your own patients. So these are things which we will try to emphasize, and that will be helpful. Now, the direct. So yes, you will have to give a direct diagnosis. So you have to say benign or malignant. So benign, this is a malignant melanocytic lesions, or you can go directly even if you want to say malignant melanoma, that's absolutely fine, providing that you tell me in situ or invasive or whatever. Yes. But this will pass you in the exam, and then you will and this what I will close the session with. In the exam, you will be scoring most of your points in a case like this lentigo maligna melanoma on applying the data set items. So you need to tell me that this represents an in situ disease. So that will be horizontal growth phase. So you don't have Breslow and you don't have Clark's level, and you do not have, you don't need to do sentinel lymph node, you don't need to count mitosis. So that's all absolutely fine. But providing that you mention that you will apply this represented horizontal phase and melanoma as one of the items which you can apply for your data set. So the data set item is not for me now to tell you what they are. You need to go to the data set items and see how the report is written, you go, even if you don't want to read it, just go to the final page of the data set, which always tell you our pro forma of report. So you go to this and you see the icons, which you need to mention them, especially if you have an invasive tumor. The summarization of the important points, unfortunately, we will have to go through them when I discuss the superficial spreading, because at the moment, guys, this is virtual because I did not show you the superficial spreading. And we are limited with the time, unfortunately, because I know a lot of people has got other commitments, so we have to respect this. Just in the next session, what will happen, that I will start with the superficial, I will start with some group of lesions, will include the superficial spreading, but I will also tell you how we will be scoring more points for these particular cases, because there are standard criteria, but it will take us sometimes to be able to emphasize on these points on how, what is the format of additional comments, that this is your fourth sections of your answer, the additional comments. And this is the fourth. I just told you one of them now, that you will need to apply your data set items to give me the prognostic criteria for a lesion like this, or for any malignant melanoma. But in the next session, I will tell you how we will be able to apply this. Now, yes, so I will apply for these final questions. How you distinguish between lentigo maligna and lentigo maligna melanoma, degree of atypia, and the pagetoid spread are the most important things. The nests are not. You see, the nests are not part of what we will be looking for in these things. Invasive cells, obviously, if you see them and the lesion progress, this is obviously a malignant one, yes. But by all means, if you are still in the in situ phase, then the degree of atypia will have to be very exaggerated atypia, not like what you see on the screen now. These are mild atypia or moderate atypia. This is not particularly severe as severe. The other one was very exaggerated. Go back to that example. And then the pagetoid spread, which you tend to see more toward the center of lesions, but in lentigo, you can also see it spread throughout. That's absolutely fine. If you are in doubt, always say that I will do immuno to confirm the presence or absence of pagetoid spread. That's sometimes in difficult cases, these things you will be doing. Again, I am always hoping to show you more cases, and we will be showing more cases in the future per session. But when we are dealing with a difficult concept that carries a lot of confusions in people's minds, it is important to stand and solid here so we can build on this. Then I can build in the next lecture and show you more and more cases where it will be getting easier and easier, and then all of a sudden you find yourself dealing with, you wish to have a melanocytic lesion in the exam. The thing is that this what I say here is difficult sometimes to find it in one text book, and you might find it in papers, and you will find it in but a lot of them, you find it in a lot of varieties of books, but we also find it in live lectures and courses and things. What we're trying to do is to summarize that up. So we're trying just to summarize all these findings and clear your brain and clear all these clouds to make it clear. This was important for me, introduction for this melanocytic lesion, because I will build a lot on this in the next sessions, and then believe me, it will all become very clear. Again, thank you very much for tuning in, and thanks for listening, and hopefully we will be able to do that. Yes, I will share them. We're just editing them. Unfortunately, we are just a little bit behind. We are just making sure the sounds fit with the recording and the things. So I will be sending the links. Hopefully, all of them, you will have the links by tomorrow or the day after maximum. So you will be receiving the links for the videos, which you will be able to access at any time. No problem at all. Thanks a lot. Okay, you take care for now. Thank you.